with regulating a number of aspects of aviation, including the aircraft, the airmen, navigational facilities, and air traffic control. There were specific requirements in this act for airworthiness inspections of aircraft, markings for identifying aircraft, tests of aeronautical knowledge for airmen, and a physical exam to ensure the physical fitness of airmen. And there were some investigations of the causes of accidents, although at the very beginning this was fairly rudimentary. Now, if anybody is interested in who to blame for the third class medical, here's your man, Dr. Bauer. Dr. Bauer graduated from Harvard just before the First World War, and in 1913 he joined the Army Medical Corps. He pretty much developed the initial versions of becoming a flight surgeon for the military, and in 1926, then President Coolidge tapped him to come out of the Army and into the Department of Commerce to essentially run the aeronautical medical branch of the Department of Commerce. Effective December 31st, 1926, there were 3 classes of medical certificates for pilots. That's transport, industrial, and private. And as you can see, this pretty much mimics what we have today with first, second, and third class medical certificates. The Commerce Act also allowed for pilots' physical qualifications to have waivers for pilots who had enough skill and experience to compensate for whatever the physical defect was presumed to be. So why do we worry about this? As physicians, why do we worry about pilots and medical conditions? There's really 2 things, and we talk about them separately, but it's really a continuum. There's a continuum from fully awake and ready to perform at top quality to unconscious or unresponsive and not able to perform at all. And in between are levels of impairment. And those levels of impairment may be very minimal or may be quite significant. And so we talk about it as going from the green zone to the red zone. When we talk about medical impairment, what kind of medical conditions are we talking about? We're talking about decreased field of view. In aviation, you're expected to see and avoid. If you can't see, you can't avoid. So individuals who only have one eye may have difficulty seeing normal field of view. Individuals with glaucoma, individuals with a retinal injury or retinal detachment may have significantly decreased ability to see and avoid. We know that there are issues with cognitive impairment, dementia, individuals who've had a brain injury. Individuals who have some other reason to be cognitively impaired may have difficulty performing the tasks required of a pilot, particularly during critical phases of flight. We have issues with impaired judgment. ADHD, it's not really the hyperactivity that's the issue, it's the impulsivity and the impulsive behavior that can be a problem. People who have bipolar disease and episodes of mania. People who have psychosis and hallucinate may not be able to differentiate between what's actually happening and what's a hallucination. All of these are potential medical conditions that might impair someone's ability to fly safely. And then there's the increased risk of sudden incapacitation. That's suddenly becoming unable to respond and perform appropriately. So individuals with epilepsy, hypoglycemia in diabetics, severe heart failure has an increased risk of sudden cardiac death or sudden cardiac arrhythmias from any other cause, recurrent fainting from unknown causes, and that actually is a real diagnosis, I swear, and coronary artery disease, where somebody may be at risk for suddenly developing an acute coronary event. One of the earliest studies that we have looking at what happens, what's the difference between pilots who are physically fit and pilots with a physical deficiency. Now, I'll be honest, I'm a doctor in the 21st century. I don't actually know what they meant by a physical deficiency, but physical deficiency and physical defect were the terms in use at the time. And in fact, this was a review by hand, essentially, of 3 years of pilot and accident data married together. And what they found was that pilots with a physical deficiency had a greater number and a greater proportion of both fatal and non-fatal accidents. And they also tended to fail out during pilot training at a much greater rate. Down below, you can see that's the actual reference to the paper from 1931. There's really been very little other evidence in the United States about medical issues with people flying legally in the US because, generally speaking, pilots have had to have medical certificates. By the way, this is a photo. This photo is plane crashed into a house, 1929. It was a prototype of the Fokker 32. There were 2 people on board who did survive, and there was no one in the house at the time of the plane crash. The other issue that we have that's different than 1926 is in 1926, remember, it was prohibition. So yes, there was alcohol around, but none of it was legal. The main kinds of medicines that were available were opium and its various friends. So laudanum, if you've heard of that. Some of these were legal, some of these were not so legal, but they certainly were widely available. Sulfa drugs, sulfa is a kind of antibiotic, and that was really the only antibiotic available at the time, and there was no such thing as the Food and Drug Administration. Compare that to today. 2015, there are about 1,500 or so drugs approved for sale in the United States, and we have the Food and Drug Administration to try and help us identify the effects, the side effects, and the adverse effects of those medications. And the problem is that sometimes those things happen in combination. Many people take multiple medications, and the effects may, in combination, may be different or exaggerated compared to the effects of any one of those drugs by themselves. So this is a little bit more complicated, and really I'm making this point because it's really complicated for the average person in the United States, and I'm going to get to some data that supports that. It's pretty hard to know, gosh, what is this drug? In fact, in the emergency department, I can tell you that the majority of people I see who are taking more than 2 drugs don't know their names. They want to tell me about the little pink pill, or it's a little oval and it has a little line down the middle. Okay, well that doesn't tell me anything about the drug itself. Okay, the other thing you should know is that we have at the NTSB some pretty clear-cut criteria for when we identify an accident where there's a medical condition or a medication involved in the probable cause. And really we have to meet these 3 criteria. There has to be a medical condition or a drug with the potential to cause impairment that we find in our investigation. So there has to be something that could be impairing or incapacitating that we find. There has to be evidence of impaired decision-making or some kind of behavior that would not be expected by the skill and experience of the pilot, him or herself. So if you have someone who goes up on their very first flight in their brand new airplane, who's had 20 flight hours total, who's solo, and who crashes on takeoff or landing, well, is that out of the realm of possibility for someone who's only got 20 flight hours? That becomes a big conversation in terms of the investigation. And then finally, whatever it is that we find, whatever the issue was, has to be associated with the accident circumstances. So even someone who's taking 4 controlled substances at therapeutic doses, who's flying a helicopter, if the rotor comes off the helicopter, that individual's potential impairment by medical conditions is not associated with the probable cause. No one can fly a helicopter without a rotor, right? So for medical impairment to get into the probable cause as cause or contributing factor, we really have to meet these 3 criteria. So let me tell you a little bit more information. Last September, we finished a safety study, Drug Use Trends in Aviation, Assessing the Risk of Pilot Impairment, and that's available on our website, as is the supporting documentation. What we did in this study is we combined the NTSB Aviation Accident Database with the FAA toxicology results between 1990 and 2012. And when we did that, here's what we found. We found that we ended up with 6,677 fatally injured pilots in the study. These were pilots where their data matched, and this represented 87% of all the accidents that were potentially available. 96% were in general aviation operations at the time of their accidents. 98% of them were male. There's a wide range of ages. And over the course of the 23 years of the study, the average age of the pilots involved in these fatal accidents increased from 46 to 57 years old. They tended to be slightly older than the average age of pilots as measured by the FAA. Here's the main finding. The The main finding is that the number of pilots with at least one potentially impairing drug increased from about 11% to about 23% over the course of the study. 2.5 times, give or take. Now, what's a potentially impairing drug? It's a drug that can sedate you. It's a drug that may confuse you. It's a drug that may give you hallucinations. It's a drug that typically carries a warning from the FDA, do not operate machinery or drive a vehicle until you know how this drug affects you. We say potentially impairing because we found the presence of the drug. We did not find that this was impairing in all of these accidents, merely that it was present. The second category is a potentially impairing condition. So again, we see a significant increase in the number of pilots with a drug, at least one drug, that indicated they had a potentially impairing condition. And those drugs were significant psychiatric disease, cardiac arrhythmias, other neurologic things such as Parkinson's, anything that might cause sudden incapacitations such as epilepsy. Those are the kinds of drugs that we're talking about. And then the purple line with the little triangles is controlled substances. Controlled substances are identified by the DEA as substances with a psychoactive effect that may lead to the potential for abuse. Okay, so in this category, controlled substances are those that are prescription medications approved for sale, and the blue line, illicit drugs, are controlled substances that are not approved for sale and were being used illicitly. And in fact, even though the increase is small, there is also an increase in the number of pilots testing positive for at least one illicit drug. Sadly, the most common drug that we found, and increasing in use over the course of the study, is something called diphenhydramine. Diphenhydramine is a drug that is so sedating, it is the active ingredient in the majority of over-the-counter sleep aids. Okay? In fact, it's the active ingredient in all of the packaging that you see here, and in almost any over-the-counter sleep aid that you can pick up in your local pharmacy. The use of this is up to about 8% in the last 5 years of the study. About 8% of the pilots had evidence that they had taken some of this drug. It's available in cold formulations, it's available in allergy formulations, and it is particularly sedating. In fact, here's the back of the box, or one of them. You can see that, of course, this is in about 6-point type in real life on the back of the box, and way down the middle it says, "Be careful when driving a motor vehicle or operating machinery. Marked drowsiness may occur." All right, that doesn't say don't fly, right? It's not very specific. It doesn't say don't drive, and it doesn't give a lot of information about for at least X number of hours, right? Because that's what you'd really like to know. You'd like to know, okay, if I take this, how long do I have to wait before I'm good to go? Unfortunately, although we know this drug is sedating, and we know in a driving simulator study that it was at least equivalent and perhaps more problematic than a blood alcohol of 0.1, what we don't know is how long you should wait before you're safe to drive again. Again, we're finding this increasingly in pilots. And about the third class medical, what we did when we looked at this was since 2005, so we only took the last 7 years of the study, the last 8 years of data from the study. And we looked at pilots whose medical was within the duration of a third class, and we looked at pilots whose last medical was longer ago than the duration of a third class medical. And what you can see is that there's an increased number of pilots, an increased proportion of pilots using all of these kinds of drugs, that's potentially impairing drugs, drugs indicating a potentially impairing condition, controlled substances, and illicit drugs in that group of pilots who don't have a medical. Now again, this study was not about impairment. It was about evidence of a drug being present, having been used before flight. Doesn't necessarily mean that it was impairing at the time of the flight. What this does for us at the NTSB is raise a concern about pilots flying without medical certificates and their safety. And in fact, what we see is more and more pilots who are crashing. This is only those pilots who fatally injured who got into our study. But what we know about the fatally injured pilots is an increasing proportion of them do not have a valid medical. And that's been going up since about 2005. When the light sport aircraft option came into play. In summary, compared to pilots with a medical certificate, fatally injured pilots without a current third-class medical certificate were more likely to have used all of these drugs potentially associated with an increased risk of having an accident. That's potentially impairing drugs, drugs used to treat potentially impairing conditions, and controlled substances. That is why we're concerned. But the big question about the third-class medical really comes down to this. Is the crash rate for pilots allowed to fly without medical certificates higher or lower than for pilots who have medical certificates? Is it as safe? Is it more safe? Is it less safe? And here's the problem that we have, and this is what we're looking for in terms of the data. Here's about, now these are round numbers, there's about 250 or so fatal crashes a year. There's about 350,000 active pilots with a third class. Now, how did I get that number? I looked in the FAA data. The FAA measures active pilots by those who maintain a medical certificate. That's how they get counted. And so that's the number of active pilots with a third class medical certificate, looking at the GA population. When you have this information, you can calculate crash rates. So you know that the crash rate of pilots, the fatal crash rate of pilots with a medical certificate is about 5.7 fatal crashes per 10,000 actively flying pilots. And if you look at that by the number of flight hours now, what is the average number of flight hours in the GA population? I canvassed my colleagues. I came up with a number. It is absolutely a guess. I used 75 hours a year. Maybe it's 100. Maybe it's 50. I don't know. I used 75 hours a year. So that's totally a guess. But if you use 75 hours a year, you get that the fatal crash rate per million hours is 7.6. Now, if we look at those pilots flying without a medical certificate, let's say there are 50 fatal crashes of pilots in this category. It's going up. It's about 24% of all fatal crashes. Maybe it seems to be going up. That was a guess to put a round number in there. I don't know what the actual number is this year. But what I don't have is I don't know how many active pilots there are in this category. I can't calculate a rate. I don't know how many flight hours they have. I can't calculate a rate. So I don't know if it's safe to fly without a medical certificate. And neither, frankly, does anybody else. What we need, and here's some numbers. I'm gonna give you a couple of examples. If there are 80,000 pilots flying without a medical certificate, then we can compare that the crash rate might be slightly higher. Is that different enough to make us change our minds about anything? I think we can have a long conversation about that. How different is different enough? How much difference in safety does it matter? If you use that same number and you say 75 hours per pilot, you get about 6 million flight hours in this category. And now you get that the crash rate per million flight hours is 8.3 compared to 7.6. Is that enough? Is it different enough? I don't know, but if you go and you change the numbers slightly, so for those with a medical certificate, these are the same numbers as a minute ago, 200 fatal crashes, 350,000 active pilots, about 5.7 fatal crashes per 10,000 active pilots. But let's change the numbers a little bit on the bottom row. So if we say there are 70,000 pilots, so 10,000 fewer pilots flying without a medical certificate, suddenly we get that the crash rate per 10,000 active pilots is now 7.1. Well, is that different enough? Is that enough difference in safety to do anything about it? And if you say that those pilots who fly without a medical certificate, maybe they fly a few fewer hours. Maybe they fly 60 hours a year instead of 75 hours a year. Well, now you get that they fly about 4.2 million hours. And suddenly you see that the fatal crash rate per million flight hours is up to almost 12, or at least 50% greater than for those who have medical certificates. Now, I would argue that, gosh, that's a lot different now. Now it's a lot different. Now maybe we really do have a problem with aviation safety that we need to address. Caveat here is, these are totally made up numbers. They're totally made up. And the problem is that no one is counting how many active pilots are flying without a medical certificate legally, and what their flight experience is like how many flight hours they're flying. And without that information, we cannot tell whether or not flying without a medical certificate is safe or how safe it is. So the NTSB has issued recommendations to the FAA asking that the FAA collect the information needed to answer this question. In particular, the number of pilots flying without a medical certificate and some kind of information about their flight experience. For those of you who have a medical certificate, the fact is you answer these questions normally as part of the historical section filled out by the pilot in the medical application. In summary, the NTSB's opinion about the third class medical. Gosh, we really don't have much experience in the United States of pilots flying without one. We have some historical information that suggests maybe it could be a problem. We have some concerns based on the results of our toxicology information. And we believe that no one is currently collecting the information to answer the question of whether or not flying without a medical certificate is a safe practice. Thank you. And can I have the lights up and ask for any questions? Yep.
Just on number of...
Hold your question.
Oh, sorry. We'll get you a microphone.
2 questions.
Sure.
Thank you. Just on the number of pilots flying without medical, can't you just look at pilot licenses that exist versus current medicals on file, subtract, and you have that number?
So the issue is we don't know how many of those pilots died. We don't know how many of them stopped flying for some other reason. So we don't know the answer to that question. Once you have a pilot license, you have it for life.
It would still give you a number, though.
But how?
It would be wrong, but at least it's better than a wild guess.
Well, the point is, why don't we get an accurate number? Right now we have no number, all right? These numbers are entirely made up, okay? We don't know the answer to this question, and until we know the answer to the question of how many pilots there are, we can't answer the question of how safe is it. That's my point.
Second question on the FAA position of not taking a position on the third class medicals. And of course, it's all the rage in the news about doing away with the third class medical. Is that going to happen? And if so, when?
Okay, so I don't speak for the FAA, I speak for the NTSB, so I can't answer the question about the FAA. I also can't tell you what Congress is going to do. So I'm here representing the NTSB, and our position on this issue is we need more information to decide whether or not this is safe, and we need to be collecting that information. I had another question. Yes, sir. In the front. Oh, okay. In the back first. We won't forget you.
I'm Martin Sobel. I'm a Wright Brothers master pilot. I flew for TWA for 33 and a half years. Still active, light sport. I've had a lot of physicals over the years, most of the time class 1. I maintained the class 1 physical until I started getting free EKGs as part of my normal annual physical. The quality of the medicals vary tremendously. I used to use a physician as my FAA physician as my primary physician. In other words, I wasn't afraid of having anything happen to me that would be evident to lose a license. There are also physicians who, if you can walk in the door, you're going to pass. And I'm talking about class 2 and even class 1 physicals. So this is something that there's no way you can put any kind of analysis on it because you don't know the quality of these physicals.
So I can't speak to the quality of any individual physical. Obviously, it depends both on the airman the pilot to be honest and forthright and complete in their information, and for the physician to follow through on that information and anything that he or she finds on the physical exam. But the FAA certifies the aviation medical examiners, and they have a process for ensuring that they provide quality care. So I would say that having a medical certificate is a little bit different than what happens when you go to see your regular doctor. That physician has specific information regarding the process of flying, the risks associated with flying, and the tasks necessary to complete the job that your average primary care physician may not have. That said, we're stuck with what we have. We don't have the ability to, have a bird's eye view into every exam room. And that's true of all sorts of medical care. Did you have another question?
Yes, my name is Bill Caslin, and you admit to making a lot of guesses. There are a lot of unknowns. You admit to that. We concede that. Perhaps you'll never get that information, no matter what you do or how you go about the analysis of pilots. But perhaps there's a surrogate, and I was thinking perhaps of highway safety, and perhaps the age of people who hold driver's licenses, and perhaps some sort of a relationship to age and accident rate of that population, and to use that as perhaps a surrogate for a population in any endeavor.
So pretty complex task. We do know that in highway that the accident rate increases significantly for drivers over age 85. I'm pretty sure that nobody thinks it's a good idea for us to simply say that no pilot over age 85 should fly. No driver over age 85 should fly, because it's not that simple, okay? It's not as simple as, gosh, the crash rate goes up. The issue is, how do we predict which of the individuals in that group are more likely to have a crash, and which ones are safe and which ones are less safe or more risky? And then the other issue with all of this is what's the risk tolerance, right? So the NTSB's tolerance for a crash rate that's going up may not be the same as that tolerance in the general population. That's something that we need to have a conversation about. Where's the cutoff? Where's safe enough? What's good enough? We may not agree on that. So those are some of the issues that are coming up. I don't think that you can make simple correlations from the driving population to the pilot population among other issues. There are a whole lot more women in the driving population than there are in the pilot population. Also, there are differences in education, et cetera, because being a pilot, maintaining a pilot certificate is a fairly expensive endeavor. And it's quite a bit more expensive than maintaining your driver's license. Other questions? Way in the back.
Hi, good morning, Dr. Has the NTSB looked into or thinking about the legalization of marijuana in transportation use?
Sure. So here's the current situation. The DOT, so the Department of Transportation, has made it very clear that marijuana is not a substance that may be used by commercial operators. That's commercial drivers, commercial pilots, that's airline pilots. Anybody subject to DOT drug testing will not get a positive test for marijuana reverted to negative by any of the medical review officers. So they've made that quite clear. The FAA, we've actually asked the FAA, the NTSB, as a recommendation right now to the FAA to clarify the position on marijuana use by pilots, by GA pilots, not subject to the DOT drug testing. Because we do see the number increasing, and it's low. It increased from about 1.6 to about 3.0% of pilots in our toxicology study that were tested positive for marijuana. That's pretty low, but that's not zero, and it's going up, and when you apply some statistics to it, it's going up significantly. And so we've asked the FAA to clarify what the regulatory position is so that all of you know what it is. Have we seen accidents involving marijuana in the general aviation population? Yes, we have. Thank you very much.
You got a question?
Oh, I'm sorry.
One other question. Okay. I really appreciate data, as do you. I'm just wondering, how would you propose going about gathering the data that you need to establish the conclusions that we need?
There's really a number of ways of doing it. And a requirement to go online and certify that you're an active pilot on every year, every other year. You go online, you enter your information, you say last year I flew 2 hours or 20 hours or 200 hours or whatever it is, and you're required to have that with you with your pilot's license when you get a ramp check. I mean, the procedure, there are dozens of other options, that's just one of them. The procedure's potentially pretty easy. It's putting in the process to make it happen. That's something we don't have right now. Okay, I think that was the last one. Oh wait, there's another one in the back. Sorry, it's kind of dark.
When is an accident and is a fatal, and how do you determine, and I seen it on reports, that this pilot was using allergy medicines and they figured that caused the accident? How do you know this pilot was using it or not using it? Do you do blood work or do you do records reports?
So if something happens in an aircraft that causes substantial damage to the aircraft and a fatal, there's a dead person involved somewhere, that's an accident. That's sort of the down and dirty version. Fatally injured pilots have toxicology testing performed by the toxicology lab at the FAA out the CAMI, the Civil Aerospace Medical Institute in Oklahoma City. All of it's performed by the same lab the same way, so it's pretty comparable stuff. And that's how we know about the diphenhydramine and the other drugs that popped up in our study. They give us a level. Hopefully we get a level in blood. Sometimes there is no blood and we get a level in other tissues. And then we have to interpret that level based on what we know about what happens to the way the drug gets spread around the body both during life and then after death. And then we have to look at the operational characteristics of the accident to try and decide, was it likely this person was impaired by this particular substance? And if they were impaired, how did that affect their decision-making or their operation of the aircraft, whatever happened in the accident circumstances? Sometimes we have long conversations about these things, but you really have to meet those criteria. You have to have evidence of a drug or medical condition. Now, sometimes our medical investigations are really limited by didn't find the body for a week. That certainly limits what kind of information we can get out of that. Or the injuries are so severe that the parts that we're the most interested in really can't be examined, and that's particularly the brain and the heart. So in some investigations, we think maybe there could have been something going on, but we just don't have enough evidence to be sure. Okay, any other questions? Thank you very much.
Thank you, Dr. McKay. Thank you very much.
Absolutely.
We appreciate the presentation. Thank you. Thank you, folks, for coming out. Our next speaker around 10 o'clock will be the NTSB for General Aviation Pilots, presented by Robert Nichols, Surveillance Services Group Manager. So I hope you'll come out and attend our next safety seminar. If you'd exit out the north door, we would appreciate it. Thank you very much.